so much for coming back so promptly. I hope everybody managed to get a cup of coffee and some refreshments during the break. We've had a brilliant morning so far in terms of introducing the clinical and patient perspective. The next session is going to cover what the science tells us, so the rationale for using heparan sulfate as a biomarker. It gives me immense pleasure to introduce Professor Frits Wijburg from Amsterdam, who's going to take you through the development of heparan sulfate assays. Thank you, Frits.
Does it work? Yeah. Thank you, Sheena, for introducing me. Good morning to you all. I hope the coffee helps you to stay awake, because now we're going for the real biochemistry. So there we are. It's about the heparan sulfate assays, because heparan sulfate has been introduced this morning as the one primary starting point of all the disease in the neuronopathic mucopolysaccharidosis. A bit about the naming, the nomenclature, which can be a bit confusing, because heparan sulfate is one of the glycosaminoglycans, which is also named mucopolysaccharide, and the disorders are called mucopolysaccharidosis because of accumulation of glycosaminoglycans, and we're talking today a lot about heparan sulfate. Biochemistry, there it is. Heparan sulfate as a molecule, it's not so much an intracellular molecule, but it resides on the outside of the cells, on the cell surface, like in antenna, capturing all kind of molecules in the extracellular space, the extracellular matrix. These green snake-like things, these are the glycosaminoglycans, these are the mucopolysaccharides. This is heparan sulfate. And so it's on the cell surface and it's in the extracellular matrix. And these green things are coupled to the red ones, which is a protein. So you're talking about proteoglycans. What are they doing? They're doing a lot of very, very important biochemical metabolic functions, not in the cells, but between the cells. They capture signal transduction. They are co-receptor for several growth factors. And you need these molecules. They're very important. They're synthesized by the cells, but it's a continuous turnover. They also need to be broken down, and that's where things go wrong if you talk about this group of diseases of the mucopolysaccharidosis. Focusing a bit more, it's this is the this is the proteins linking tetrasaccharide, and this is these long molecules, these green serpent-like structures. And the nature of this disaccharide, repeating disaccharide units, determines if we're talking about heparan sulfate as glycosaminoglycan or the others, dermatan sulfate, keratin sulfate, or chondroitin sulfate. Heparan sulfate is today the most important molecule we are discussing, because heparan sulfate is abundant in the brain, in the extracellular matrix in the brain. And if it starts to accumulate all these processes on the previous slide, like this, they will go wrong. And Maurizio Scarpa this morning beautifully showed what can happen if they start to accumulate. So again, the protein over here, the linked tetrasaccharide, and here is heparan sulfate, dermatan sulfate, chondroitin sulfate, and keratin sulfate. All very long molecules, but with repeating disaccharides and sugar molecules over here. So the different GAGs, glycosaminoglycans, are characterized by different sugars and different sulfation patterns. We will focus on the heparan sulfate. And again, a bit of biochemistry. If you look at this molecule, you have this end of the molecule we call the non-reducing end. And this is the reducing end of the molecule. This is important because if this molecule is broken down in the lysosomal space, it starts at this end. The non-reducing end is where the breakdown of the molecule in the turnover in the lysosomal compartment starts. So you've seen this before, but I think it's important to realize that if looking at the different mucopolysaccharidoses, only those with heparan sulfate accumulating, they have this progressive neurodegeneration, this progressive brain disease. It's like childhood dementia. It's the heparan sulfate that drives the brain disease. There's no doubt about that. And this goes more deeply into this non-reducing end. This is heparan sulfate, only the non-reducing end. And if heparan sulfate is broken down in the lysosome, it's a stepwise procedure involving lots of different enzymes, where there's an enzyme that can be an enzyme deficiency due to genetic defect. And here are the disorders related to the different enzyme deficiencies. So you can easily understand that every specific enzyme deficiency leads to a specific non-reducing end biochemistry. The molecules on the non-reducing end differ with the different syndromes. Until 2015, measuring the GAG concentration or the mucopolysaccharides or heparan sulfate was done by a dye-binding assay with a two-dimensional electrophoresis. That appeared to be not sufficiently sensitive and specific for the purposes we are discussing today. Very fortunately, from after 2015, a new chemical technique was developed to measure very specific, very sensitive the concentration of these molecules, and that's done by liquid chromatography, tandem mass spectrometry. Highly sensitive, highly specific, and that's what you need for the purpose of heparan sulfate assay we are discussing today. Basically, there are two approaches to measure this heparan sulfate in biological fluids: blood, urine, and especially central cerebrospinal fluid. You can do a non-reducing end assay looking at the specific disaccharides on the non-reducing end of the accumulating heparan sulfate. That's absolutely a very sensitive and specific way of measuring this. It can help in the differential diagnosis because I showed you that all these different enzyme deficiencies lead to different non-reducing and disaccharides. It's been used, for instance, in the US for newborn screening purposes for different MPSs. Highly sensitive, highly specific. Another approach is and that's probably more widely used, is the internal disaccharide assay, in which the molecule over here is completely digested enzymatically, and all these different carbohydrate molecules or disaccharides are measured by tandem mass spectrometry. Also very sensitive, probably not always as specific, but for the purpose of follow-up in a treatment trial for a specific disorder, a differential diagnosis is not needed, and specificity is not so much the thing, but sensitivity is. Can also be used as a second-tier newborn screening for specific MPSs. For instance, in the Netherlands, we use this assay for the MPS 1 newborn screening. Both assays now, and I can say this very confidently, are sensitive and validated for heparan sulfate measurement in cerebrospinal fluid. They have been used in several treatment trials in neuronopathic mucopolysaccharidosis, like MPS 2 and MPS 3, showing a very significant reduction of the concentration in CSF in some of them, or most of them actually. So coming to my conclusions, it can be measured. It can be measured sensitively and specifically, wow, what a word, in cerebrospinal fluid. There are different assays, but I think that's not really very important. It's as long as you use one assay in a trial and use these standard procedures. And I think most importantly, a change in heparan sulfate concentration is related to clinical response. That will be shown today, this afternoon, by different presentations. And in my opinion, it's a very sensitive biomarker to be used. The thing is, the response of heparan sulfate is rapid, and that has been shown to you this morning. If you look at clinical changes, that may take years, like 3, 4, 5, 6 years, and this can take months. And that's a tremendous difference, very important. Thank you for your attention.
Thank you so much, Frits, and that time is of the essence in these conditions. I'd like to welcome Dr. Grant Austin from the Washington University School of Medicine. And just a reminder for those online, please submit your questions through the online question and answer portal. And those of you that are in the room, don't forget your index cards. Harriet is waiting to collect those questions. Thank you, Grant.
Hello. Thank you all for the opportunity to speak here today. I'll be sharing some work by Patty Dixon's lab, where I'm a postdoctoral fellow, determining where CSF heparan sulfate is coming from and whether or not it is actually a marker of neurologic disease. So I don't have any disclosures. Dr. Dixon has some disclosures there. I won't belabor these points. Many of them have already been made, but neuronopathic MPSs are caused by heparan sulfate accumulation. There's lots of problems with current clinical trial design using neurocognitive and behavioral endpoints, and so we need something different. Brain biopsies are not really an option, so looking at the CSF is the best option, and looking at heparan sulfate in the CSF would be a reasonable assumption as a biomarker of CNS disease. And in several animal models that we've looked at in our lab, we do see that heparan sulfate correlates with brain heparan sulfate. So this is in MPS 3D mice, and you can see the brain on this side, the CSF on this side, with increasing doses of enzyme replacement, and in both cases, as brain heparan sulfate goes down, CSF heparan sulfate goes down as well. This is in MPS 1 dogs treated with intrathecal enzyme replacement therapy, and again, as brain heparan sulfate goes down, so does the CSF heparan sulfate. And there are many other examples that others will touch on as well. Unfortunately, we also see some correlation with the periphery. So this is in MPS 1 dogs. Again, this time they were treated with IV therapy, both a high and a low dose, and in both cases, brain glycosaminoglycans decreased significantly. And these are MPS 1 patients treated again with intravenous therapy, and their CSF heparan sulfate goes down, and the amount that the CSF heparan sulfate goes down, the serum heparan sulfate also goes down. So we're left with a bit of a muddy picture of where's this CSF heparan sulfate coming from. And so one hypothesis is that it is originating from the brain, and therefore it would be a good biomarker of CNS disease. And this would indicate that some of our intravenous enzyme therapy might be crossing the blood-brain barrier, maybe not in a therapeutically relevant amount, but enough to lower some CSF heparan sulfate. Or hypothesis 2, the CSF heparan sulfate is coming from a pool of both the CNS and the periphery, and therefore it would not be a wholly reliable marker of CNS disease. So our problem then is, how do we just treat one compartment in the body to isolate where this CSF heparan sulfate is coming from? And so to do that, we used gene therapy, which can be pretty extensively modified to answer our questions. So the first modification we made was to link our therapy to LAMP1, which is another lysosomal protein, but this one is membrane bound and tethered to the lysosome. So other lysosomal proteins might get secreted. If we tether it to LAMP1, it will not be, and therefore you'll only treat intracellularly and not secreted heparan sulfate. And this was shown by Mark Sand's group. He used Gal-C enzyme and proved that this works. Gene therapy can also be placed into different viral vectors. This has been shown by many, many groups that different viral vectors affect different areas. So AAV7 only affects the periphery. It does not get into the CNS. So if we treat with an AAV7 viral vector, we're only going to treat peripheral disease. AAV9 goes everywhere, so it will treat the CNS. And if we add a CNS-specific promoter, then it will only treat the CNS and it will not treat the peripheral tissues. So as a summary of our experimental design, if we have an AAV7 vector with LAMP tethered to NAGLU, which is the deficient protein in MPS 3B, we can treat only the peripheral disease in MPS 3B. And if we have an AAV9 vector with a neuron promoter, synaptin-1, with LAMP tethered to NAGLU, we will only treat MPS 3B neurologic disease. So to prove that this works, we first looked at, is it going specifically where we want it to go? So these are enzyme activity assays. Blue is going to be our peripheral treatment with the AAV7. Green is our CNS treatment with AAV9. With our peripheral treatment, we get no NAGLU activity in the brain. We do see it in these peripheral tissues. We also don't see it in the serum, which is important because, again, we don't want secreted enzyme because that would muddy our results. For the AAV9 central nervous system treatment, we only see NAGLU activity in the brain, not in the peripheral tissues and not in the serum. We then wanted to make sure that these treatments are disease modifying because we want to correlate heparan sulfate levels with whether or not disease is actually being treated. So for our peripheral treatment, again, blue, so we're looking at the AAV7 peripheral treatment. We're looking at beta-hexosaminidase activity, which is another lysosomal protein that is accumulated in lysosomal storage diseases. But it's not the enzyme that we're treating with. So when signal goes down, that's good in this assay. So we don't see any treatment effect in the brain with our peripheral treatment. The hexosaminidase is still at disease levels. But in the periphery, especially the liver and the heart, we do see a pretty substantial decrease in the beta-hexosaminidase levels. For our CNS treatment, we looked at markers of neuroinflammation, which has already been talked about as a significant part of these diseases. So this top row are untreated MPS 3B mice. The blue dots are markers of microgliosis, so CD68. The red is GFAP, which is a marker of astrogliosis. Both of these are very high in these untreated animals. For our treated animals, we see high levels of NAGLU, which means that our treatment is getting in and being expressed. We don't see hardly any microgliosis. We do see still some GFAP signal, so it's not readily clear from these images, but when we quantify the whole brain, we do see a reduction in GFAP. So there is a reduction in neuroinflammation in these mice as a result of our treatments. So that means that our gene therapy are getting to where we want it to go, not going where we don't want it, and is disease modifying. So then the question becomes, does CSF heparan sulfate correlate with these results? And we see that. So in this peripheral treatment, the AAV7 blue treatment, There's basically no reduction in heparan sulfate in the brain, in the CSF, but there is reduction in the serum. So treating the peripheral tissues led to a reduction in the serum. In the CNS treatment, we see substantial reductions of heparan sulfate in the brain because of our treatment, substantial reductions of heparan sulfate in the CSF, but not so much in the serum. So when we treat just the brain, we reduce heparan sulfate. When we don't treat the brain, we don't reduce heparan sulfate. And so from that, we can conclude that when you treat the brain, you reduce heparan sulfate, and the heparan sulfate in the CSF is a marker of that reduction, which means that it would be likely a very good marker for clinical trials to measure whether or not treatments are impacting the brain. And I would just like to acknowledge the lab, especially Patty Dixon for giving me this opportunity to speak, and Stephen Lee and Al Sorensen who did the majority of this work. Thank you.
Thanks so much, Grant. Can I please introduce Matthew Ellinwood? Dr. Ellinwood is the Director of Sciences and Research at the National MPS Society USA. Thank you, Matthew.
Thank you very much for the introduction. I am both an employee of an advocacy organization and also an emeritus professor who had a long research career in the MPS disorders. I'll provide an overview of some of the historical aspects of heparan sulfate and its role in neuropathology, and I'll be focusing on comparative medical aspects as well as a preclinical study involving MPS IIIB that was associated with the Allevix trial. As I reflected on giving this talk, I asked myself when, in fact, as a community, did we really associate heparan sulfate with neuropathology? When I started in 1998, it was one of the foundational concepts I was trained on. And I decided to go into the literature and look at exactly when we had identified this as a group of scholars. And indeed, this goes back to the very beginning of the field. Back before we had the nomenclature from Victor McCusick on the MPS disorders, they were all called Hurler syndrome. And in this study from 1964, they identified a condition, an atypical form, this was Sanfilippo, primarily degeneration associated with the nervous system, excreted only heparan sulfate in the urine. This distinction was followed up within a decade to correlate neuropathology in the neuropathic MPSs with heparan sulfate in the CSF, and this was work done by Decaden and Constantinopoulos. A positive correlation between the high levels of acid mucopolysaccharides in the CSF and the progressive mental deterioration is postulated. All forms had heparan sulfate that had neuropathology. So this is an ancient, as it were, from a scholastic standpoint, association. It is also deeply conserved in biology. We've heard from our scholars today, my fellow colleagues, about the association among all of the neuropathic MPSs that have heparan sulfate storage as the primary accumulation. All MPS types without heparan sulfate are free of neuropathology, including MPS 4A, B, 6, 9, and 10. All mammalian models of these disorders that have neuropathology are primary heparan sulfate storage disorders. We see this in cattle, dogs, goats, cats, mice, and swine models. We also see another level of conserved biology, and that's the evolutionary conserved biology. And there's a great example in MPS IIIB, where we see occurrence of this disease in humans, of course, in mice, dogs, cattle, swine, and in emus. These have all been characterized clinically at the molecular level, at the histopathological level, at the biochemical level. When we think about the conservation of this neuropathology, it spans 310 million years of chronological time. But biology doesn't work that way. It's conserved across all these different lines of evolutionary time, and we see, when we aggregate these, that is conserved across nearly 1 billion years of evolutionary time, the association of stored heparan sulfate and neuropathology. This was one of the paper from one of the trials that Dr. O'Neill discussed as one of the failed trials for 3B. It is the trial that had extended the longest. This was an enzyme replacement therapy directed into the CSF, similar to the approved therapy for Batten disease, CLN2, a treatment called Brineura. We did the preclinical work for this in the dog model. This is a spontaneous dog model. It is the longest, largest, and most comprehensive CNS-directed therapy in any model for a neuropathic MPS disorder. So I will spend some time discussing the details and the findings of it. It was an intraventricular and intracisternal infusion approach in the spontaneous 3B model. The route was designed to overcome the blood-brain barrier, and it was an equivalent approach of delivery to the Brineura model of treatment. We infused either 12 or 28 milligrams of alpha tralicinidase alpha, a recombinant form of NAGLU. So it was also a dose-finding study. The recombinant enzyme had a insys tag to help cell uptake. We infused animals with 48 infusions over 20 months. The majority were intracisternal infusions. We had difficulties maintaining the ports in the animals, and starting around 5 months and going to 2 years. I wanted to spend some time and let you see what the disease looks like in the MPS 3B dog model. If we could roll that movie, that would be great. Clinical disease in the dogs starts at approximately 18 or 24 months of age, and it's primarily a cerebellar ataxia. Within 12 to 18 months after onset of disease, the animals are humanely euthanized. And we see all postural instability and a particular reflex we see in veterinary medicine called cerebellar rebound, where they can't control their head movement. We see neuronal storage throughout the brain with astrogliosis and microgliosis, shown here in the trigeminal nucleus. And the end result is a profound cerebellar atrophy that we see at end stage in the dogs. All forms of MPS 3 in canines share a neuropathology. We see it across all 4 forms in the dog. It presents as early onset cerebellar atrophy. This is not a model, this is an adult onset, but it does model severe disease in the animal model species. We wanted to look at the correlation of CSF and tissue GAGs. And as you can see here, the correlation is excellent between vehicle-treated 12 milligrams and 48 milligrams in the tissue and the CNS. And these are non-reducing end approaches. When we look at CSF GAGs, again, heparan sulfate measured by the disaccharide method and by the non-reducing end method. At 48 milligrams, we are eliminating storage in these tissue compartments. And the CNS and the CSF are well correlated. We also wanted to look at the response of tissues and behavior in the animals, and we embarked on a number of studies targeting the cerebellum. You can see in animals that are treated with vehicle, as their cerebellum atrophies, you get CSF intercalation and higher signal in the cerebellum. We can measure that with DTI. This is an untreated animal with a high level of CSF water movement in the DTI images. We see normal, and we see a dose-response curve over time in these animals. And we can graph that as mean diffusivity, which is higher in the vehicle-treated animals and is normalized and is in a dose-dependent fashion. Functional responses in the cerebellum can also be seen. Remember that head bob movement. We knew from the beginning we were designing this study as a prevention model. It was designed really optimally to treat individuals before they had any onset of disease, optimally through newborn screening. We don't have that for 3B. Hopefully, if we get a treatment, we can start testing. For example, in the United States, 85% of the birth cohort is now tested for newborn screening for MPS 1. That's a viable approach to 3B in the future. So this was our setup to test the cerebellar rebound. We would raise the animal's head. We would capture that kinematically. and we saw a real tremendous preservation of normal cerebellar rebound in the treated animals. These were the vehicle-treated affecteds. We also did learning along a T-maze, and we found that the normal animals learned very well from the beginning to the end of the study. The affected untreated did not, and the affected animals also learned to perform the T-maze reversal quite well in the end. So conclusions. Comparative biology and medicine shows that among the 7 distinct disorders of MPS, we see conserved neuropathology. This is seen across 6 species, incorporating 2 phylogenetic classes, 4 orders, and at least 127 million years of conserved evolutional biology. We see a strong correlation in CNS tissues and CSF heparan sulfate, and we see multiple modalities evaluating the therapeutic intervention to positively demonstrate that these enzymes will improve tissue pathology and behavior and preserve the architecture of central nervous system tissue. With that, I would like to thank my colleagues and the organizers.
Thank you so much. Thanks so much, Matthew. Again, really, really informative. Our next speaker is actually online. David, can you hear us? David Whiteman.
I can indeed, yes, thank you.
Perfect, thank you so much. David, I'm going to hand over to you to talk about the role of heparan sulfate in advancing clinical trial development. Thank you.
Thank you, and thank you for the organizers for asking me to take part in this meeting. And good morning, everybody. Good day, wherever you are. I'm going to take a slightly different tack here and look at the historical example of idursulfase development, the enzyme replacement therapy for MPS II. I believe this could have been approved based on a toxic biomarker intimately related to the genetic and biochemical lesion as early as 2002. And along the way, I will offer some comments about how decisions are made in the pharmaceutical industry and how some of the events that you've heard of from other people earlier this morning played out. Next slide, please. I'm not going to dwell on this. It's essentially a pretty illustration of some slides that other people have shown already. But the important point is that the glycosamine glycans are these long-chain molecules. The sequence of enzymes is necessary to break them down. When the first step enzyme fails, all the others cannot operate, and these GAG fragments accumulate. And I'm going to refer to GAGs because at the time we started this work, all we could measure was total, mainly urinary GAG, glycosaminoglycans GAGs. Next slide, please. So I want to go back through the development history, and I also think this could be a model for how we develop things differently in future. Hunter syndrome was defined clinically by Charles Hunter, a Scots physician from Elgin, a town between Inverness and Aberdeen. In 1917, he attended the Aberdeen Medical School and then moved to Canada to join the Royal Canadian Army Medical Corps, and ultimately ended up being a consultant pediatrician in Winnipeg. He saw an English family that was visiting Canada for, quote, winter sports shortly before this paper was published. And he noticed that there were 2 boys who had very similar features and an unaffected sister and unrelated parents. This is a beautiful clinical description of what we now call Hunter syndrome. And if you've not read it, I suggest you might want to do so at some point. It's one of the first clinical descriptions that shows X-rays and clinical photographs. And he correctly posited that this was likely a genetic disease and that it was also possibly X-linked. So we have a defined clinical syndrome. In 1973, the biochemical basis of that syndrome was established through work of Elizabeth Neufeld and colleagues and the discovery of a Hunter corrective factor in cross-cultured cells. And this is now known as iduronate 2-sulfatase. That same group, particularly Dr. Munzer and Dr. Neufeld, provided further clinical characterization of the syndrome. And in the 1980s, Ian Young and Peter Harper in Britain published a series of papers further delineating the natural history of MPS II and essentially identifying the neuronopathic form. Now we shift more to industry and development. In 1988, a group of scientists from Harvard Medical School and investors set up a company, biotech company, called Transkaryotic Therapeutics, the Therapies, or TKT, to develop treatments based on gene conversion. From a clinical perspective, that was never successful, i.e. they were never able to do in vivo gene conversion, but the methods they developed allowed them to manufacture a number of recombinant human enzymes. In 1993, 5 years later, John Hopper's group in Australia first cloned the gene and then showed expression of that recombinant human hydrogen 2-sulfatase. Next slide, please. In 1993, TKT began preclinical development of the recombinant. I'll just call it I2S from now. They called it DRX006A, and it eventually acquired the INN of hydrosulfase. In the late 1990s, Dr. Munzer and I both ended up consulting for TKT for different purposes. Dr. Munzer, obviously, on Hunter syndrome and that development program. I was actually working with them on development of a database, what we would now call a registry, initially called the FIRE registry and subsequently the Fabry Outcome Survey for Fabry disease. The preclinical studies, the first clinical study, phase 1, began in 2001 and confirmed a rapid, over 2-week, urinary GAG reduction in MPS II in a dose-dependent manner. And several doses were tested. I'm not going to show the details here. And ultimately, a dose of 0.5 milligrams per kilogram body weight administered weekly was selected for the next registration trial. I had been able to see that data as it was developed, and my previous work was really as a clinical pediatrician and medical geneticist, mainly interested in case series and registries. And I looked at that data. I said to myself, we're reducing the toxic metabolite here, and we've shown that we can do it in a dose-dependent manner. So I went to my new boss, having finally joined the company, and I said, we should try and register this way. And needless to say, I was told to go away because nobody was thinking about biomarker approvals at that time. What we did do was a phase 2/3 registration trial, classic design, 2-to-1 randomization, and we confirmed the urinary GAG finding in a larger group of patients. Improvements in 6-minute walk test and pulmonary function were shown. Fortunately, we had statistical success on a combined endpoint analyzed by non-parametric methods, the so-called O'Brien modification of the Wilcoxon sign rank test. And some people have heard me say this before, but we were lucky because of the two assigned endpoints. The 6-minute walk test did achieve statistical significance, but the pulmonary function barely did. Nonetheless, in 2006, the US FDA gave us a marketing authorization, and 6 months later, the then EMAA did the same thing. If anybody wants more details of that part of the history, they can look at this article below. Next slide, please. Now, I'm just going to briefly show some of the details of these various trials. So the phase 1 trial, 12 patients only, randomized double-blind, essentially 3 groups of patients at different dose levels and a 4th on placebo. And as you've heard, the GAGs are reduced within 2 weeks of initiating therapy. Notice also that the effect of this on liver volume, and actually applied to spleen as well, but I'm not showing it, were equally dramatic. And the first measurement point in the trial was week 18. We now know from subsequent data and expanded studies that these GAG levels are falling literally to 70 to 80% simply with the infusion of the enzyme. And the liver spleen response is similar. From a safety perspective, 6 of the patients developed IgG antibodies. They did not appear to influence the clinical course, and there were no anaphylactic episodes. Next slide, please. The phase 2/3 clinical trial was obviously more complicated, multinational randomized, double-blind placebo. using the 0.5 milligram per kilogram per dose every week and every other week, it became clear that every other week was less effective. And also with hindsight, and I'm going to make a number of hindsight observations, which don't necessarily criticize myself or other people, but it's now clear that a dose of probably 0.8 or 0.9 milligrams per kilo might have been a better choice. This happens in drug development. You learn as you go along. So I'm not blaming anybody, including myself, for that. But it's something to remember as we move forward. The primary efficacy endpoints, again, with composite measures, and essentially confirmed what we had suspected from the phase 1 trial. And again, from a safety perspective, there were antibodies developed, as you would expect from infusing a protein, but they did not appear to influence the urinary gags. They did appear to have a transient effect on the urinary gags, so they did not correlate with any of the clinical variables. Next slide, please. Now, around that time, we had started thinking about a trial of intrathecal idursulfase for reasons that everybody already understands. And there were many discussions. The company was taken over by another company at that point, and the new head of clinical development decided that I didn't have enough clinical development experience and sent me off to Switzerland to run medical affairs and education and marketing programs. Colleagues developed this phase 1 and subsequently phase 2-3 study for intrathecal administration of idursulfase. And the details are in this paper here. This is a very simple concept, essentially a portacath placed below the skin and the front of the abdomen and tracked back by tunneling into the spinal space. And CSF was withdrawn, analyzed, and drug. It was placed in equivalent volumes. Next slide, please. I'm not going to go any further on the IT trial at the moment. We'll come back to that. But two things occurred or were developed in the further development history of idursulfase. The first was starting, actually it originally started in 2004, but the first findings were reported later on. Essentially, the Hunter Outcome Survey, what we would now call a registry, or at the time it probably wasn't a registry. It was actually developed as a safety and database and for marketing purposes, showed that these findings were confirmed over the longer term. As expected from idursulfase alone, there was no improvement in cognitive function as measured. However, I would point out that when I was responsible for idursulfase, the most frequently reported adverse event was hyperactivity for about the first 2 years. And that was of some concern to the regulatory agencies. We discussed it. In retrospect, the patients were waking up somewhat. Why were they waking up? They were breathing better. Their hearts were working better. The enzyme doesn't cross the blood-brain barrier, but those other factors essentially led to some improvement in their function, and I think we should all remember that. The other important study that occurred around that time, and I apologize for the typo, we haven't reached 2012 yet, is a study of MPS II boys who, I say suffered because they did suffer, an administrative withdrawal of previous idursulfase therapy. If people want to know the details of that, they can read this paper from Poland. But essentially, it showed that there was rapid reaccumulation of the urinary gags over about the same time course that it decreased when the idursulfase was started, and a corresponding deterioration in clinical findings, particularly liver and spleen volume. And finally, I just mentioned this graph on the right from a very recent publication from colleagues at my former company, which summarizes from the literature, these are all published cases, the rate, if you will, and the progression of falling of glycosamine glycan concentrations, or in some cases deduced or measured heparan sulfate concentrations over time. It's really a dramatic fall at the beginning here. And in fact, if you track this out, it continues to fall. Next slide, please.
David, I can give you 30 seconds.
Okay, I think I can do that actually. So in summary, MPS II is a precise primary genetic biochemical lesion. We know the gene, we know the enzyme. Others have eloquently expounded on the biological clinical consequences. I don't really consider heparan sulfate so much as a biomarker as I do as a toxic metabolite, and others have used that word already. It's basically a poison. And it was initially analyzable only in total gags and subsequently with more precise methods, as Dr. Wijburg just described. But this is a poison. If these kids were being poisoned by lead with these kinds of results, particularly the neuropathic results, we wouldn't be waiting 20 years to do something about it. In the case, I'll skip through this part here because other people already said it, and the community consensus from last year summarizes it. But we know that heparan sulfate is the neurotoxin. Next slide, please. Oh, and I should just mention, of course, likewise for Sanfilippo syndrome. So there's some challenges in clinical trial design here. Looking back at it over 25 years, and it's a real world experience, we could have provided safe, wider access to children and adults using this toxin, if you will, surrogate approach to idursulfase. Likewise, we could have done the same thing as recently as 13 years ago for the children who received intrathecal idursulfase. Not only would that access have been considered beneficial by the families and children, but a definitive answer to the clinical efficacy and safety over a longer time period needed in a real world setting could have been obtained. In retrospect, in the case of idursulfase IV, it was, and that's published. There are others have said this, but there are major challenges for small biotechnology companies being expected to do what would amount to a 10-year study. And one of the findings from Haas is it took us 10 years to establish that there was in fact a survival benefit to Hunter syndrome individuals treated with idursulfase. Most companies can't tolerate a 2-year clinical period, and investors are even more impatient. And then, as others have said, there have been failures of previous trials when companies simply couldn't meet the required endpoints in the shorter time frame that they could offer. And finally, I just want to comment that the choice of appropriate endpoints can be limited and is complicated in clinical trials. They're not always completely up to the company physicians and scientists. Sometimes it's dictated by commercial and marketing interests in the company. They want to see a particular endpoint because they think they can, quote, sell it better. And sometimes regulatory bodies have requested specific particular endpoints, particularly instruments like EQ50 and so forth. So in summary, we're looking at a toxic disease here. Is this a biomarker? I think that term gets overused, but it's certainly a surrogate for the toxic disease. And we could have acted much faster. And now with these new trials that you're going to hear about this afternoon, we must act much faster. The children can't wait any longer. Thank you.
Thank you so much, David. And that's really set up the next presentation from Spyros Batzios from Great Ormond Street Hospital. The impact of failure of trials.
Excellent. So good morning from me as well. I think that my talk is quite different from the 4 previous lectures on this session because the previous speakers have given you scientific data about clinical trials and biomarkers, but what I will do is that I will try and appeal to your emotions because basically, as you know, the brain does not work without the heart. I suppose that fortunately or unfortunately, medicine doesn't work as well without emotions. My financial disclosures. And I'm going to start with a simple fact, which is that trials fail. And sometimes they fail for good reasons. They fail because the drugs are not working or they are not safe. There is this publication, which was published almost 10 years ago in the Journal of Pediatrics. It was about the discontinuation of randomized clinical trials conducted in children. And what the researchers have found is that 1 out of 5 clinical trials in children, they fail. And the main reasons why they fail is patient accrual, conduct problems, or informative termination because the drug is not safe or is not working well. And then there was this publication, which actually is a very good publication, a meta-analysis published last year about the same issue, about the discontinuation of randomized clinical trials in children. And this research has actually shown that it's not 1 out of 5, it's 1 out of 3 clinical trials in childhood that they fail. And something that I really liked is that they said at the end of their paper that 85% of those clinical trials, they fail because of preventable reasons. And one of the reasons that they mention as preventables is financial hardships. Now, trial discontinuation for financial purposes is not something new. It's something that is happening since clinical trials started, basically. And I'm giving you here the example of a publication of a clinical trial. This was about a type of statin back in the old days. And basically, I mean, this is a very unethical example, I think, because this trial was discontinued because the sponsor has learned that there was another statin that would be authorized and released in the market before the trial is terminated. And because of that, basically for marketing purposes, they just decided to stop their clinical trial and left hundreds of patients without treatment. I was not part of the previous trial, thank God, but I was part of 3 clinical trials so far in my career that they failed. One of them was because we couldn't recruit patients, and the other 2 were because of financial reasons. And I'm giving you here the example of tralicinidase alpha in patients with MPS IIIB. Matthew has already spoken very well about this trial. My personal opinion is that this trial was very well designed. It used outcome measures that were appropriate, including clinical measures, neuroradiological measures, and also heparan sulfate and heparan sulfate non-reducing ends as biochemical measures. And it was not only in the animal models, but it was as well in humans that we had direct evidence that this treatment was working. Nevertheless, on the 31st of October 2023, I've received the worst email of my career so far, which was actually saying to me that effective as of today, the same day, I needed to stop every action related to this clinical trial. And the reason why this has happened is because the sponsor, after years of negotiations with FDA and EMA in order to achieve accelerated approval of tralicinidase alpha in MPS IIIB patients, they have been failing. And actually, the regulators have requested to do another clinical trial in order to gather additional data. And the company was unable to raise sufficient capital in order to support this trial. So because of that, they've decided to stop the treatment. Like, in order to give you a little bit of context, I was already in dispute with the company because 1 month before that email, they told me to stop the treatment in 1 out of the 2 patients that I had in the trial because the patient did not fulfill the cognitive criteria in order to be participating in the extension phase of the trial, even though my experience and based on the tests that we have been doing to the patient, he was doing quite better when compared with patients who have been untreated with MPS IIIB. But the other thing, which was actually very frustrating on the day that I've received the email, the second patient who was still on the trial received a general anesthesia in order to continue gathering data for the trial. So this patient who had MPS has been through a general anesthesia in order to get data for the trial the day that they told me to stop the trial. So when I was asked to speak about, to give this lecture today, I thought that, that's a very experiential issue here. So I need to use basically the opinions of my colleagues, doctors and nurses, and of the families that have been related to clinical trials that have failed in GOS, in order to just give you their opinions on, what it feels when a trial fails. So some of my colleagues, for example, they said that they felt shock and extreme sadness when trials ended because, by taking away this promising new treatment from families, it puts everyone in a very difficult process. On that specific trial as well, we had limited information on why the trial stopped and what the future would look like for our patients. Other people said that there was animosity towards the drug company by one of the families, which was actually very understandable. And it was very difficult for us to remain professional at all times. Like, I wanted basically to yell at everybody, but I was bound as a doctor to just keep my professionalism, which put us as a medical team in a very difficult position. The other thing was as well uncertainty about the future. There was a treatment there, and this channel was stripped away from the families. And it was actually very hard not knowing what withdrawal of the trial therapy would look like. While other of my colleagues spoken about fear. They said that they were afraid about what may lay in store for other patients we look after, for whom it is difficult to provide concrete measures of treatment efficacy due to the complexity of their neurodegenerative diseases and the lack of a solid biomarker. Basically, what they have been saying is that they have been concerned that other similar trials might either be suspended or not start in the first place. And of course, these are what my colleagues said. The situation about families, as you've seen this morning by Mark and Kim and Kara, is a little bit different, because for families, we speak about the lives of their children. So parents said that they felt mental anguish. They needed to take extended leave from their employers. They felt depressed. There were children actually which have been asking their parents on whether they've done something wrong, and because of that the trial has stopped. And there were other parents as well that they lost significant weight, struggled to cope, and that, although we as the medical team, we've tried our best in order to make them feel good, still there was a fragmented and ad hoc approach from the pharmaceutical company that caused confusion, fear, and uncertainty. And I mean, it is a 10-minute lecture, so I need to stop at some point, because I had more to say about what people feel when we stop trials. But I suppose that I was able to show you that the effect of trial failure on health professionals and patients and families is quite devastating, because it poses emotional challenges, ethical challenges, logistical and communication issues, and also it has to do with our morale. So because, as I said, based on the presentation of this paper, of the meta-analysis that has shown that 85% of the reasons why trials fail are preventable, we need to do as much as we can in order to reduce the rate of trial failure, which is to identify promising drugs early, to better stratificate our patients, and to prioritize biomarkers as outcome measures. But what I want to finish with is that actually sponsors should not feel exonerated from responsibility towards patients just because they fund the clinical trials. When we sign this consent form, the consent form is not only a signature where we show that we've informed patients about the potential benefits and the harms of being recruited in a clinical trial. It is as well the image of a moral contract where all parties basically say that they promise that they will do the best that they can in order to have benefit for the patients and the families. And basically, by having benefit for patients and families, we need to commit to finish the clinical trials, to complete them, unless there are data that they show that there needs to be an early termination of the trial because of safety or efficacy issues. Thank you very much.
Thank you so much, Spyros, and it's really heart-wrenching to hear some of that feedback, both from the clinical community, but also from patients and families. We've got a few minutes for questions, and we have had a few online and paper questions submitted. I'm just going to hand over the microphones to the panel. So if you wouldn't mind sharing the microphones between you. The first question that I have has come from someone in the audience. Maybe Matthew or Frits might be able to respond. It appears that most clinical studies are measuring disaccharides which require additional processing step. Could you explain that in a bit more detail? Do you see there's an advantage of this over, I'm trying to read the writing, over one of the assays over the other? Does that make sense?
There are two methods to measuring the disaccharides by mass spectroscopy. One is to digest with methanol, and the other is to digest with an enzyme. For our purposes, there is no real difference. You've got to be, there's no real difference between those two for this kind of effort. Brilliant. Would you agree, Frits?
Yeah, I fully agree, and I think from the clinical point of view, from the medical doctor, there is no difference in collecting the sample. It has to be sent to the lab, so I don't think it really matters what you do, as long as you use one method during your study.
Excellent, thank you. And then one of the questions we've had online is, what are the most important criteria for determining a biomarker's clinical relevance in MPS? Who'd like to take that one? Matthew?
Does it cause disease? And I would say heparan sulfate does. And does its elimination prevent disease? And I would say the preponderance of the data and of biology says it does. Anybody else? I mean, it's a very simple answer. Yes.
Simple but very true.
Okay, excellent. And then, can patients with normal HS levels still qualify for clinical trials?
Well, I think patients with neuronopathic mucopolysaccharidosis will not have normal heparan sulfate levels in cerebrospinal fluid. It will always be
So
increased.
by default, they would potentially be eligible for trials.
If it's increased.
If the trial
Yeah,
criteria.
if it's, you need to know, of course, if it is a neuronopathic phenotype of the disorder. And this can be done either based on genetic analysis, clinically, of course, that's first, clinically, genetic analysis, family history, and in combination with increased level of the heparan sulfate in the cerebrospinal fluid.
Thank you. Matthew, this one's for you. Why did the MPS 3B trial fail or not result in a approved therapy?
I think Spyros sort of detailed that better than I did. I think that the required registrational trial was too big an economic burden, but Spyros has more details.
No, it was exactly that they've required more data basically, and because of that they needed another clinical trial which would run for another 3 to 5 years, and the company couldn't afford to have this trial done.
So just to maybe circle back, this is a question I'm adding of my own, but would the introduction of heparan sulfate as a biomarker or other tool have facilitated a better outcome in this particular situation if we'd been more aware, educated earlier?
I think that it could, and actually the results of the trial which are published have shown that heparan sulfate and heparan sulfate non-reducing ends have been significantly decreased in those patients. But unfortunately, it didn't make any any change at the end.
Thank you.
I think, in fact, it did, except the company could not raise the capital. After the Reagan-Udall Foundation seminar, they were given the option of moving forward with an accelerated approval using heparan sulfate, and were at that stage moribund and could not raise the capital. So absolutely it can. When used properly and when given at a time when a program is young enough to achieve its goals.
Thank you. Thank you. Another question for you, Matthew. We very much put you on the spot today. Very nice MPS 3B dog data. Do you think it's fair to think about heparan sulfate as a toxic metabolite? And I think we've kind of heard that from the presentations today. Toxic metabolite of cognitive disease. Provided treatment is delivered early, so pre-symptomatically in animal models. Otherwise, in more advanced disease patients and model symptoms, is it a good marker of treatment reaching brain cells?
I think if you're using the CSF, it's absolutely a good model of treating brain cells. And the optimal outcomes will be in a pre-symptomatic patient, but we saw today the outcomes for a patient like Cole, and he's stabilized, and that is not the normal activity of a severe hunter child, running around, getting on a bus, that puzzle. I mean, that's impressive clinical result. So even with established disease, these therapies have important benefits.
And then just thinking about the measures of cognition maybe being too strict, somebody's picking up on a point that Cara made in her earlier presentation about the Cure Sanfilippo study. Do we feel that those measures need to be different? And are the changes in those domains highly significant in the cognitive, the measures that we're using from a cognitive perspective? Do we need to think about them differently?
I don't think that they should be different, because those are scales that we have been using for years and they have been standardized. It's just that they should be used in addition to other things, as for example biomarkers, which are showing disease activity. Because with neurodegenerative disorders, we know that sometimes the patients cannot cooperate in order to fulfill those tests. And it's not about, at the end of the day, what is the outcome of just an isolated cognitive test. It is a combination of different parameters that will say whether the drug is working or not working.
I also think, additionally, that we need to be looking at the preponderance of the evidence. Get an accelerated approval, get your confirmatory trial structured, and I bet you dollars for donuts, these things are going to roll over to full approval. I just have no doubt that that's the case. You're going to be dealing with a diverse population, and you need to be assessing them with appropriate diversity and looking at the preponderance of the evidence.
Fantastic. Just checking, Sophie, any more questions online? No. In which case, I will no longer hold you from lunch. You have 50 minutes for lunch. Sophie, is lunch in the restaurant? So lunch, for those of you that are here, is in the restaurant. Again, those of you online, please make sure you just turn your cameras off. Don't eject from the link, because it's difficult to get you back on board. But thank you so much for a fantastic morning. Just a quick reminder, the first session after lunch where Simon was going to speak has been cancelled, and we're just going to go straight into Carol Ho's presentation. Thank you.